Alright, nephritic syndromes. These are a little fun here. So, like I said here with the RBC cast, that is the one thing that I really want you to pay attention to. So let's talk about nephritic syndromes. What are they? Let's talk about some signs and symptoms of what is a nephritic syndrome. It's basically an inflamed, damaged glomerulus, okay? Inflamed, damaged glomerulus. So you're going to see hematuria. You're going to see red blood cell cast. The patients are probably going to present with like a smoky. They're going to say, "Doc, I got a tea-colored, cola-colored, or smoky-colored urine." It's on the urine dipstick. You're going to see 4 or more positive red blood cells, and the RBC cast or dysmorphic red blood cells you will see on your analysis. That is how you know you're dealing with a nephritic versus a nephrotic syndrome. Okay. So you're also going to see mild to moderate proteinuria, unlike nephrotic syndrome. It's going to be less than 3.5 grams per day. It's usually greater than 150 milligrams per day, though. So you might just want to keep that in mind. Remember, 3.5 grams of protein is the most the liver can make in a day. You're going to see a decreased GFR. Remember, these are damaged and inflamed glomeruli. Yet renal tubular function is still intact. Now, what do I mean by that? I mean the concentrating ability of the kidney is still intact. Even though the GFR is down, you can still concentrate the urine. You're also going to see oliguria with this. Now, you're going to see a decreased clearance of a couple things, though, that's going to cause some azotemia. That is a decrease of BUN, creatine, and uremic toxins. So therefore, you're going to see an increase in BUN and serum creatinine with what ratio? You tell me. That BUN creatinine ratio's got to be greater than 15. That's very important to remember that. So you also know that you're dealing with a nephritic syndrome instead of a nephrotic. You're going to see some salt retention, so that's going to lead to some hypertension. You're also going to see some periorbital edema. Now tell me, why would you see periorbital edema? Because you got salt retention, right? Yeah, of course. You're going to see hypertension. You're going to see some salt pulls water, so you're going to get some edema. It's usually more in severe cases, though. So, moving on. That's what basically sums up a nephritic syndrome. And the hallmark, now, I want you to tell me this. What is the hallmark of a nephritic syndrome? RBC cast. That's why I wrote them in there. RBC casts are the hallmark of nephritic syndromes. So moving right along, post-streptococcal glomerulonephritis. First of all, let's talk about. We're going to talk a lot about this bad boy. Let's talk about first what strep are we dealing with here? We're dealing with group what? Group A, B, C. What are we dealing with? We're dealing with group A. A, which is beta hemolytic streptococcus pyogenes. Now that's not all. You got to have a certain well that is all. It's I need you to know it's group A beta hemolytic streptococcus pyogenes that causes this post-streptococcal glomerulonephritis. But there's certain serotypes especially important with this. I'm gonna change colors for this guy. I want you to remember these serotypes. That's M1, M4, and M12. So 1, 4, and 12. Those suckers right there, M1, M4, and M12 serotypes of Streptococcus pyogenes are especially nephritogenic strains of Streptococcus pyogenes that cause post-streptococcal glomerulonephritis. All right, so this is also known as proliferative post-streptococcal glomerulonephritis, or acute proliferative, I should say. So. Okay, so let's talk about how do we get this. This is usually from when a kid's had a URI or a skin infection with one of these strains, and he's going to present 1 to 4 weeks later. Now, why is it 1 to 4 weeks later? Because that's how long it takes to make the antibodies. So you're going to see an increased what? Increased anti-DNA ACE-D antibody. Anti-DNase B antibody and form immune complex. Immune complex. That's why we see this right here. This right here, this immunofluorescence, this IM. That's why it's lighting up, because they're forming immune complexes, okay? Now, sub-epithelial, which is also known as sub-podocyte immune complex deposition in the glomeruli with subsequent activation of what pathway of the complement cascade? The alternative. That's right. Now, what type of hypersensitivity would this be? That's right. It's type 3 hypersensitivity. Good job. Good job. So you're going to see decreased, see right here, so they got C3 in here in this picture. You're going to see decreased C3 levels, but you're also going to see normal. Catch this. You'll see normal C1 and C4 levels. So that's a tip-off on the USMLE for post-streptococcal glomerulonephritis. You're going to see decreased C3 levels with normal C1 and C4, activation of the alternative complement pathway, type 3 hypersensitivity, immune complex deposition. Now, C5a, what does he do? He recruits neutrophils. So therefore, you're going to get, look at this glomerular series very carefully. You're going to see glomerular damage there. Okay, he recruits neutrophils. Remember, this is acute, so of course you're going to see neutrophils in here. But C5a, he's the one that recruits C5a. Think of him as neutrophil recruiter. C5a is your neutrophil recruiter. He recruits neutrophils to damage and inflame glomeruli. That's why we call it glomerulonephritis, with a large hypercellular glomerular infiltrate due to the white blood cell infiltrate and proliferation of mesangial and what other cells? Endothelial cells. Now, I want you to note this though. Even though the renal tubules are not the primary target during acute attacks of glomerulonephritis, the renal tubular function remains largely intact. So what am I really trying to say there? Your concentrating ability remains intact. Remember, we talked about that with nephritic syndromes. You can still concentrate the urine when you get these, even though you see blood in the urine. Okay, so very good. So what are we going to see on light microscopy when we look down here? When we look down here at the light microscopy, what are we going to see? We see large hypercellular glomeruli. On immunofluorescence microscopy, you see a granular coarse deposition of IgG, IgM, and C3 along what? The glomerular basement membrane, and one other thing, the mesangium. Okay? Now, on electron microscopy, you're going to see a large sub-epithelial, remember sub-podocyte, sub-epithelial, sub-podocyte, electron-dense deposition. That's where you're going to see the bumps and the humps. Okay, that's on electron microscopy, which I don't really have a picture of that for you, but I want you to notice here the main one is this C3. Notice that you're going to see a deposition of IgM, IgG, and like I've already circled, C3. Okay, now what's the classical presentation of this? It's going to be a young child. Most likely it's going to be 6 to 10-year-old with a history of upper respiratory tract infections like maybe pharyngitis, or they could even go for impetigo like a skin infection or scarlet fever. And it's always going to be 1 to 4 weeks ago. They're going to develop a sudden fever, nausea, malaise. Signs and symptoms of nephritic syndrome is going to be your hematuria. Obviously, your Coca-Cola, your mom's going to come in and say he's got weird colored urine, or the kid's going to tell you that it's smoky colored, it's tea colored. You're going to see RBC cast on the urinalysis when you get it. Oliguria, azotemia, everything we've already talked about. You're going to see some mild edema, example like the periorbital edema, and it's also going to be a little bit hypertensive, okay? But remember, azotemia with a BUN creatinine ratio greater than 15 because renal tubular function is still intact. He can still concentrate his urine. Okay, very good. I think you understand post-streptococcal glomerulonephritis now. So moving on, what is rapidly progressive glomerulonephritis? Okay, now this one's quite complicated, but we're going to simplify it. I want you to know, like we're going to talk about here, there's 3 types of rapidly progressive glomerulonephritis, and this is a really not good thing, but I want you to understand the pathophysiology behind it, because if you understand that, I think you can understand the rest. What happens is, I'm not going to write all this out for you, so you're going to have to listen. You have a rupture in the glomerular basement membrane that triggers the formation of crescents. So whenever you see that word crescents, let it trigger your mind to RPGN. So allowing the infiltration of monocytes, which is nothing more than a macrophage, and a macrophage into Bowman space, Bowman space is the urinary space lined by the visceral epithelium, i.e. the podocytes and the parietal epithelium. Now what happens is you allow leaking of fibrinogen, which is a protein, a negatively charged fibrinogen, right? Because you're damaging the glomerular basement membrane. Now you get this fibrinogen in Bowman space where it's converted into fibrin. No blame O. Once this fibrin is converted from fibrinogen, you get a triggering of proliferation of parietal cell epithelial cells into the lining of Bowman space. See, and what happens is that starts to compress. Look at that. It's compressing. So now on light microscopy, you're going to see crescents and a collapsed glomerular tufts. That's where all this comes from. Collapsed glomerular tufts. That's what we're talking about when we're talking about all these. What do you think you see? Here's a good question for you. What do you think you see on, we're not going to talk, I don't want to go into immunofluorescent microscopy because we're going to have to talk about all 3 types there, but we are going to go into that here in a minute. What do you think you're going to see on electron microscopy of RPGN? That's right, rupture of the glomerular basement membrane. Good job. And that's what lets the fibrinogen leak in, and that's what lets it turn into fibrin, and that's what allows it to build up and collapse these tufts. And now we got problems with their GFR, yada yada yada. So what are the 3 types of RPGN? Well, we got type 1, type 2, and type 3. No surprise there. Type 1 is mediated by anti-glomerular basement membrane antibodies. And he is ANCA negative in most cases. Type 2. This one is mediated by immune complex deposition. Like I said, I want to keep this as simple as possible. See the big picture. And type 3 is what is known as posse immune. So you got lack of glomerular basement membrane antibodies or immune complexes. Lack of glomerular basement membrane antibodies or complexes. So that's pretty simple, right? We just simplified the crap out of this. So type 3, we can talk about all the ones now. Let me ask you this: what will posse immune be? This one is the one that's going to be, you tell me, ANCA positive. So that's when we start talking about Church-Strauss, like Wegener's microscopic polyangiitis, all those with the P-ANCA, the P-ANCA, the C-ANCA. Which one of those 3 that I just mentioned between Wegener's, Church-Strauss, and microscopic polyangiitis is C-ANCA positive, or also anti-proteinase 3 antibodies? Wegener's. Very good. Remember, these are type 3 caused by systemic vasculitis. So that's what posse immune stands for. It's the lack of the complexes in type 2 or type 1 you don't have antibodies against the glomerular basement membrane. So it's literally that simple. Don't make it no more complicated than it is. So moving on to Goodpasture's disease. What is this? Goodpasture's disease, obviously, as you can see, it's got an immune complex, or it's got an immune response to it because of the immunofluorescence. You're going to see pulmonary hemorrhage here. Pulmonary hemorrhage, so you're going to see things like hemoptysis. That's usually the first presenting sign. You're going to see also cough, maybe some shortness of breath, dyspnea. Now, a couple weeks later, you're going to see what? Rapidly progressive renal failure, signs and symptoms of nephritic syndrome like hematuria. So that's the second presenting sign. So the second presenting sign is rapidly progressive renal failure. You're going to see what? Hematuria. So if you see something in a vignette that says you're coughing up blood and then you start peeing blood, I want you to start thinking of something like Goodpastures or something like that, because that's usually what's going on here. Now, what type of hypersensitivity is Goodpastures? The pathophysiology behind this is it's always a guy. It's usually a young adult in their 20s and 30s, and it's males way more than females. They're not going to give you a female with Goodpastures. They could, but I don't think they will. It's a type 2 hypersensitivity reaction. You got anti-glomerular basement membrane antibodies that bind the Goodpasture antigen, which is a peptide within the non-collagenous portion of the alpha 3 chain of type 4 collagen. I know that's a lot of stuff that you won't remember, but that's okay. So on immunofluorescence, what do you see? You see smooth linear depositions of IgG and IgG and C3, smooth linear deposition of IgG and C3. Okay, moving on to Alport syndrome. What is Alport syndrome? Obviously, it's a nephritic syndrome. Now, there's three things. You get hereditary nephritis, which is going to give you hematuria and red blood cell cast. Let's write that in there. Number one, hereditary nephritis, hematuria, RBC cast. Number two, this is a big one, senso neural hearing loss. That's a big one right there. Remember that guy. Number three, ocular problems or abnormalities, let's say. And like that's lens discoloration, posterior cataracts, corneal dystrophy, things like that, etc. So if you see someone with nephritic syndrome, sensorineural hearing loss is the one I always look for, and ocular, anything dealing with ocular problems, whether it be posterior cataracts or lens discoloration, right away go to Alport syndrome. 85% of the cases of Alport syndrome are X-linked recessive. X-linked recessive, a defect in the alpha 5 chain, type 4 collagen. The remaining 15% of cases are autosomal recessive or autosomal dominant defects in the alpha 3 or alpha 4 chain, but just remember that 85-90% is the alpha 5 chain, which is X-linked recessive in the type 4 collagen. Regardless of the inheritance pattern or the specific defect involved, all cases of Alport syndrome are caused by a defect in what? Type 4 collagen assembly. Type 4 collagen assembly. All cases. So it's a structural and a functional defect. So you're going to have a glomerular basement membrane. That's what gives you nephritis. You're going to have cochlear hair cells of the inner ear. That's why you get sensorineural hearing loss. You're going to get the lens in the cornea of the eye. That's why you get ocular abnormalities like the lens discoloration or dislocation. On electron microscopy now, you're going to see irregular thickening or thinning of the glomerular basement membrane with, here's the key word, splitting of the lamina densa. This often gives the glomerular basement membrane a basket weave appearance. So splitting leading to basket weave appearance. That's Alport syndrome in a nutshell for you. So moving on, IgA nephropathy. What do we know about IgA nephropathy? I would definitely remember this one. This is also known as Berger's disease. I should have wrote that in there for you. Sorry about that. Berger's disease, or I call it Berger's. This is the most common cause of nephritic syndrome worldwide. I didn't say the U.S. now. I said worldwide. Okay? And it's an important cause of recurrent hematuria, gross or microscopic. Recurrent. You hear that word, recurrent hematuria? IgA nephropathy right away. Click and move, baby. On light microscopy, you may show a normal appearing glomeruli or mesangial widening due to the mesangial proliferation and or deposition of immune complexes. Now, I should have put you in immunofluorescence because this is immuno, this definitely has a specific immuno look to it. Basically what you see is mesangial deposition of IgA, IgA1 actually, often with C3 and propyridine. You see those three things, and they say if we were to draw mesangial, I'll draw it in here for you, what it might look like. So if we have a glomerulus right here, and then you'll see on light microscopy, it'll be like lit up here, here, there, there. It'll be like lit like there. So you'll see all these little mesangial depositions of all this IgA. It won't be smooth and linear like in Goodpastures, etc. So moving on. What do we know about on the EM, the sub-endothelial versus the sub-epithelial depositions? Actually, one more thing I wanted to talk about. IgA nephropathy is associated with Henoch-Scheinlein purpura. So you're going to get a purpuric skin rash. It's IgA-mediated small vessel vasculitis, and we know all about Henoch-Scheinlein purpura. It's also two other things. So HSP, celiac sprue, IgA-mediated bowel disease, anti-gliadin, and IgA antibodies, and dermatitis hepatiformis, where you get group vesicles on extensor surfaces. So there's three diseases there. That's HSP, celiac sprue, dermatitis hepatiformis. So moving on. With the sub-endothelial deposition, you get a diffuse proliferative glomerular nephritis. That's nephritic. That's due to usually lupus. There's also a less common nephrotic subtype that is sub-epithelial. Now, type 1 membranoproliferative glomerulonephritis, that EM shows tram tracking due to mesangial proliferation. More commonly presents as nephrotic syndrome with hematuria. So that's the sub-endothelial. Think tram tracking. Also lupus, SLE. Now let's talk about the sub-epithelium. That's going to be seen in your post-streptococcal glomerulonephritis, which is nephritic. That's going to be membranous glomerulonephritis, also known as diffuse membranoglomerulopathy, which is a nephrotic syndrome. This is going to give you a spike and dome appearance. So tram tracking, lupus, sub-endothelial, sub-epithelial, spike and dome, or post-strep GM. So what about the sub-endothelial deposition? Like we just said, that's going to be due to diffuse. I'm going to write it in here for you just so you'll have it. Diffuse, number 1, diffuse, proliferative, glomerulitis, nephritis. 1, membranoproliferative glomerulonephritis. Okay. Now, sub-epithelial, number 1, post-strep GN. Number 2, diffuse membranous glomerulopathy, or membranous, we'll just say. Glomerulonephritis. Alright, so what about other types of depositions? What other things can we see? How about IgA nephropathy, like in Berger's disease? We see mesangial depositions there. What about intramembranous depositions within the glomerular basement membrane? You see that in MPGN type 2. Intramembranous deposition. Okay. Now that's the one where you're going to see a little tram tracking or whatever. Now, how about if there's no visible depositions by electron microscopy? Give me a couple diseases you might see that in. How about Goodpastures? That would be a great one. You're not going to see anything on EM. How about Alports? How about focal segmental? Glomerulosclerosis, which is that nephritic or nephrotic? Hope you said nephrotic. How about minimal change disease? Is that nephritic or nephrotic? Hope you said nephrotic. So, let's see here. There's only really one nephritic syndrome, which is usually, the RBC cache that's usually immuno involvement that you cannot see on electron microscopy. What one would that be? That would be the first one we talked about, Goodpasture's disease. You cannot see that there. That's also known as type 1 crescentic glomerulonephritis. Okay. No, there are antibodies to the glomerular basement membrane, but there are no electron-dense electron depositions visible on electron microscopy. So you have to diagnose it by immunofluorescence. And how about chronic glomerulonephritis? Chronic glomerulonephritis is not always preceded by an inflammatory inflammation. Not preceded. It can be now. can be. It's a rapidly progressive glomerulonephritis is the most common cause, okay, followed by focal segmental glomerulosclerosis. On gross appearance, the kidneys are symmetrical and they're shrunken. And diffusely they're granular. Microscopically, you're going to get scarring of the glomeruli, so you're going to have to do a trichrome stain, showing the blue staining collagen in the glomeruli. Also, microscopically, you're going to see a high-line arteriolosclerosis, which is thickening of the walls of the arteries and the narrowed lumens, secondary to what? Hypertension. That's exactly correct. And you're also going to see some interstitial fibrosis. So the trichrome will show blue staining collagen between the glomeruli. Okay, so remember the trichrome stain of this guy. And he's going to show blue staining collagen because collagen stains blue. Between glomeruli. Okay, you're also going to have some tubular atrophy and lymphocytic infiltrates. Now, the clinical presentation of this thing, how do you think this is going to clinically present? Well, we're going to have hypertension, we're going to have proteinuria, and we know we're going to have azotemia. We're also going to have gross bloody urine. That's rare though, although microscopically it is present. Waxy cast, that's a good buzzword for you. Waxy cast. See waxy cast, you're going to see hypertension. You're going to see anemia. Secondary to lack of what? Erythropoietin. So you're going to get fatigue, malaise. You're going to see, without treatment, this is going to lead to uremia. We all know about that GABA connection. What that's ultimately going to do is shut you down and lead to death. So this has to be treated. How do you treat this? You treat it with a renal transplant, or you dialyze them. And that pretty much sums up nephritic syndromes for you. Very good. A lot of information, but go over that a few times and you'll have it down. That's what I want you to remember about Goodpastures, and literally it's that simple.